did that with Mr. Jones with CHF, so we're doing it for coronary artery. We're gonna start just a minute here. Everybody else trying? I don't. And I don't have the right printout, because this has got 21 questions, that's only got 19, so I'll find out what I'm missing. Thank you, thank you, thank you, thank you. Assess, 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 assess. Look at that beautiful zero on all the other things. I love y'all. Very good job. All right, so Mr. Bob, he's going to be our coronary artery disease case study. He's 40 years old. He's having chest pain. He's having shortness of breath. His heartbeat feels like it's fluttering. What do we need to do? We need to assess before we intervene. We need some lab work. We probably need to provide some information and assess. Assess, assess, assess. So let's learn some more, just in general. I should ask more questions before we did this one. All right, so I should ask some more questions before we hit this, but that's fine. So Mr. Bob is our coronary artery disease case study. So we're talking about his coronary arteries are narrowed to the point that his heart is not getting perfused well, causing chest pain. So chest pain is caused by the lack of perfusion to the heart muscle. So coronary arteries, remember, are on the outside of the heart. And if any of those are narrowed, we're not going to get good perfusion. If we don't get good perfusion, tissue starts to become ischemic and it hurts. Women, so I had to throw this slide up here, a lot of women do not have your classic chest pain symptom. A lot of times they present with GI type issues, which comes off as indigestion. So women should never ignore chronic indigestion that doesn't seem to match up with, hey, I just ate some spicy food, so now I have indigestion. Like if we just have indigestion for no reason, for women, that's going to be potentially be a cardiac sign. It could also be pain elsewhere, not in the chest. So when we think of chest pain, we think of right here on top of the chest. What's the character like when people describe it? Yeah, very tight, very pressure, like there's something heavy on my chest. That's kind of the typical character. What else with the pain? It can go down the arm, it can go up the neck. With women, they can just have those radiating symptoms. Like they may just have neck pain or just have arm pain without the chest signs, without that heaviness. All the other questions we want to ask, like what helps it get better, what helps it get worse. We're going to kind of get into that a little bit more. We always want to rate pain, so don't forget that. We always want to rate pain because we're going to intervene, so we got to see if it's getting better. So with most people, also want to add, it's not just women, a lot of times elderly folks too. This also, indigestion is also a sign of chest pain. So coronary artery disease, chest pain, we have risk factors for those. So let's talk about modifiable and non-modifiable risk factors. Very good job. So we have modifiable, non-modifiable risk factors. So our non-modifiables, we'll go with that. So age, what's the highest risk? What age group? Unfortunately, it's middle-aged to older, so 50s and 60s and older. Yay. Ethnicity. Our African Americans tend to have higher risks for coronary artery disease. Gender or sex, well, we got males or females. Which one's higher risk? Males are going to be higher risk. What else is non-modifiable? I left one out. Genetics, family history, that's non-modifiable. All right, modifiable. Stress, very good job. What else is modifiable? Diet, exercise, smoking. Alcohol's not a huge risk for coronary artery disease. Smoking is, though. Diabetes, hypertension, those things that can be controlled with medication. So those are all modifiable risk factors. All right, let's get back to Mr. Bob. Well, this is gonna be fun, because that one wasn't on my printout. I cut out questions and I added more, so. All right, good job. So he's got some lab work that we're gonna draw. He's probably gonna have all this lab work drawn. So let's talk about what each one of them are gonna tell us for Mr. Bob. So we're looking at coronary artery disease, which means we're trying to pinpoint, are we having narrowing of that blood vessel, so the arterio and the atherosclerosis. So we want to know his cholesterol and his triglycerides. BNP level, what's that going to tell me? Contractibility is going to be more for heart failure. Troponin and myoglobin. Muscle actual damage. So I do want to know this, because this is going to tell me if he's crossed over into a heart attack world, or if we're still dealing with coronary artery disease. And then the same thing with CK and CKD. Are we in a heart attack world, or are we still in coronary artery disease? 114, we're doing coronary artery disease. 211, you're doing heart attacks. So we're gonna go all the way up to heart attack. And then stop. Very good job. Fluttering heartbeat, what could that be? If so, that's a subjective symptom. He says he feels like he's got a fluttering heartbeat. What could it be? Palpitations is a subjective sign too. What could be going on with his rhythm causing those subjective symptoms? PVCs, AFib. I don't know. So I need a 12 lead EKG to figure it out. Is he appropriate for a stress test? No. Why? Already got chest pain. He already failed. Yeah, he failed before he hit the door. He has chest pain. So he is not appropriate for a stress test at this point in time. Troponin, yes, I want that, but that's not going to tell me about the fluttering heartbeat. That's just going to tell me if he's crossed over in my world. Echocardiogram, is that going to tell me about his fluttering heartbeat? That's subjective symptom. No, what's that echo going to tell me about? Structure, contractibility, ejection fraction, blood clots. It's not going to evaluate that subjective sign of a fluttering heartbeat or the subjective sign of palpitations. That's what I need an EKG for. Look for PVCs, look for dysrhythmias. our word for chest pain. So, 'cause of course we have to have a medical word for chest pain. So angina is that. So coronary artery disease is caused by narrowing of the coronary vessels. So if it's caused by narrowing of the coronary vessels, what do I need to do? I need to open them up. So nitroglycerin is a vasodilator. So it's going to open up those coronary arteries. So furosemide, I don't need it right now. Tylenol, I don't need none of that stuff. I don't need any. So the main thing with chest pain is I don't want to treat it with analgesics. Not going to help. So I need to treat the cause of the chest pain, so I need to vasodilate it out. Very good job. So we have different types of angina, so let's define these. So we have stable angina, which means you're having chest pain, but when you sit down and rest, it gets better. You may need to take some nitroglycerins because we send people home with nitroglycerin prescriptions all the time. So you can take up to 3 nitroglycerins and your chest pain improves. So that's stable. So you have no other signs and symptoms, no other problems, and you rest, take your vasodilator, your chest pain gets better. If your chest pain gets better, what's that telling me about what's going on inside the body? It's going to make you open up, and what's all that's going to open up? So now we're going to get blood perfusion to the heart muscle itself, so it don't hurt then, right? The only reason it hurts is because it's not getting perfusion. So if I sit down and rest, I take my nitroglycerin, and the chest pain goes away, I know that heart muscle is getting perfusion. Now, if it doesn't go away, or if I have other signs and symptoms, then we're going to call it unstable angina. So if he takes his 3 nitroglycerins and he rests and the pain still persists, that is unstable angina. The next step is a heart attack. Okay, so we're going to progress from stable angina to unstable angina to a heart attack. So for 114, we're doing stable and unstable angina. Up here?
Yeah, like, what, is there a special number, like, is it specifically 3?
Oh, it's just the dosage of the nitroglycerin.
Okay.
Because it's dangerous to give more.
Okay.
Yeah. We'll get, when we do our next we'll talk about like the risks and everything to go with this. I think I've got one question on here, but Prince metals, this is in your reading, so if you see it, I just want you to know what it was. That's a vasospasm, which is kind of separate from everything else we're talking about. So when you see that word, just know, whoop, that's a whole separate thing, not even gonna go there. So just throw that right out. For 114, we're gonna do stable angina, unstable angina. Treatment for stable angina is just what we said. Rest, take your nitroglycerin. That's the treatment. You probably need to go get some diagnostic tests done. If you're dealing with stable angina, what diagnostic test should you go have done? Okay, you can do a stress test, but you probably won't fail it. So what's the next step? Next diagnostic test. You'll have 0 confidence. Angiogram, heart cath. I need to go look at the coronary arteries because they're having some problems. Alright. Stable angina, if it continues to persist, is probably going to move into unstable. Like we need to go to the cath lab, we need to figure out the problem, we need to deal with the cause, so that we don't progress even further. Unstable angina, that's where we're at. We're going to start treating it with the next couple questions. Heart attack treatment is going to honestly be the same as unstable angina. It's just, it's worse. It means your heart muscle just turning ischemic, but heart attack, it's actively dying. So we wanna prevent that from happening. This is just fun. What did I do? Because I gave you the answer to that one, because you asked it. He already took 3, he can't take another one. So we've got to do some more interventions. We need to do all those other things. So why do we need to give him some oxygen? I didn't tell you in O2 staff. Because what's the heart not getting? It's not getting perfusion, it's not getting oxygen. So we live in a supply and demand world. His demand just went, whoop. So what do we need to do with our supply? Whoop. Back up there with it. So we tend to give oxygen 2 liters nasal cannula. Why are we putting him on bed rest? Not heart rest, don't get up. We put him on monitoring because we are always watching out for a heart attack. He could move from unstable angina to a myocardial infarction at any moment in time. So we're always on the lookout trying to make sure that that doesn't happen. So, but we can't do another nitroglycerin. We need to do some other interventions at this point. Let's see if that's the next question. Okay, cool. He's in unstable angina. Unstable world, we need 2 IVs. Cardiac diet, why does that not need to be done right now?
Probably irritating.
It's not important and he needs to be held NPO. Why?
In case you go to surgery.
He may have to go to the cath lab, may have to go to surgery. He could code on me any minute. So he's unstable, I need to hold an NPO. Head of the bed flat, why is that a no? Not helpful. When would I put his head of bed flat? What situation would make me lower his head of bed? If his blood pressure dropped on me, then I would lower his head of bed. Other than that, I want him up. Discontinue O2. Why is that a no? Supply's still up here. We need to keep, or the demand's still up here. We need to keep the supply up. Very good. Troponin, why? Alright, see if there's any. The troponin is gonna be our indicator if we're in unstable angina or if we've gone into a heart attack. So we're gonna do that troponin. So I need to ask Mr. Bob one very important question about his pain in order to best evaluate my result of this troponin level. What question should I have asked him about his pain? When did it start? What if he said my pain started right before I came into the ER? Right, the troponin may not be elevated because he just had pain. What if he tells me my pain started last night? Then if it's gonna be elevated, it's gonna be elevated. So if it's negative, I can further evaluate that result better. So in order to evaluate my troponin level, I have to know how long has he been having pain. So I need that critical question, that little piece of information, in order to understand my result better. Otherwise, I'm just kind of guessing at this point. So I want all those lab values, but I need my troponin. I need to see if he's transitioned from unstable angina to a heart attack. That's my differentiating factor along with my 12-lead EKG. So my EKG lets me know if we've moved into a heart attack or as well.
But your car has to time them.
It's gonna have a delayed elevation, so it takes a couple of hours to elevate. Yeah, it's a couple of hours. That's why we do it typically like a stat and then like 3 hours and then 6 hours. Aspirin. Ooh. All right, so let's talk about all these. All right, so he is coming in with chest pain. He's got unstable angina because we've already given him nitroglycerin. We said we could do 3. We can't do any more than 3 because it gets too dangerous on us. So now we've got to move to other medications. So our other medications are aspirin. Why are we wanting to give him aspirin? Because what is aspirin? It is an antiplatelet. So if we have a narrowed vessel, I don't want all the platelets to clog up that narrowed vessel. I want those platelets to freely kind of move through there. So I'm going to give him aspirin. I'm going to tell him to chew it up because I want it to hit his system quickly. So we're going to chew up that aspirin so that hopefully that narrowed vessel won't get clogged up. I'm going to give him metoprolol. What's metoprolol? It is a beta blocker that is going to help decrease the workload of my heart. It's also going to prevent, I'm probably answering the question later on here, so y'all remember when the question pops up. It's also going to prevent him from going into SVT, tachycardia, like we want to keep that workload down on the heart. So we're going to give beta blockers for chest pain. And then morphine, we're going to give that not necessarily because of the pain aspect of it, but it decreases workload of the heart. Because it's going to decrease your blood pressure, it's going to decrease your heart rate, and then it's going to help with the pain too. So we have our little acronym MONA, morphine, oxygen, nitro, and aspirin. That's how we remember what all we give for chest pain. So the treatment's the same for unstable angina and heart attacks. So all the stuff we're talking about, y'all remember it for 211. So then we're going to add in a beta blocker. So MONA plus a beta. So that's what we're going to do for unstable angina. We're going to chew up an aspirin. We're going to put nitroglycerin under your tongue. We're going to give you some oxygen. We're going to start out and give you some morphine and metoprolol. Vessels and see what's going on for him. Down pre-procedure, we lay them flat. Post-procedure, informed consent, yes, we know that's a risk. Why is acetylcysteine and bicarb something that can be done? It's not always done, but it can be done. In case they have kidney issues, because what do they inject during a heart cath? They use contrast dye, and we know contrast dye and kidneys don't jive very well. So acetylcysteine and bicarb can protect those NPO after midnight if he comes in at midnight, or we keep NPO from time of admission till the heart attack. Just so we don't have any problems, we don't wanna be vomiting and coding all together. Except. So don't y'all dare gag me every 15 minutes for an hour, every 30 minutes for an hour. That's a lot. Don't gag me. But we want to do all these other answers. We want to look at the groin, because what are we watching out for? Any type of bleeding, hematoma development, any of that stuff. Pulses, what are we verifying?
Blood flow.
Blood flow, that our pulses maintain the same bilaterally, that they don't change. Back pain, why am I worried about back pain?
Because they're aorta.
Yeah, there's you a picture of what it looks like on the inside with a retroperitoneal bleed. That's our worst complication of a heart attack. Thankfully, I've only seen like 2 people ever have that, so very scary. Very good job. So heparin is a what? It is an anticoagulant. It's going to prevent a blood clot from forming. It will not unblock his coronary arteries. It will not break up a clot. It's just going to prevent one from forming. It can be used for DVT prophylaxis, but we are not using that for that reason in this patient. So the reason he is on it is to prevent a blood clot from forming, because right now he's in unstable angina. We don't want to transition into a heart attack. Clopidogrel is Plavix. Very good. So clopidogrel is it's an antiplatelet. So we give aspirin to work quickly, work fast on like the front end when someone's having unstable angina. But then after that, aspirin is a one-time dose. We don't keep coming back and making you take aspirin multiple times. So typically clopidogrel is our go-to for, like, you do the aspirin in that initial acute episode, and then we're going to start clopidogrel on you for maintenance. It does not break up arterial clots. The purpose is not to cause bleeding, but we know it can cause bleeding. And it's not an adjunct. So heparin is anticoagulant, clopidogrel is an antiplatelet. So they work on 2 different sides of the coagulation cascade.
Meg is making a comeback.
The main reason we're doing metoprolol is to decrease the risk of SVT, lethal dysrhythmias, VTAC, because if the heart is not getting perfused, little sections of the heart are going to be very irritated and mad and can trigger a beat, which can send you into lethal dysrhythmias. So we give metoprolol. Yes, it does decrease the blood pressure. Yes, it does lower oxygen demand. Yes, it decreases the workload of the heart. But the actual reason we're giving it is to decrease the risk of dysrhythmias. So it's actually a core measure for chest pain. So if I say core measure, do you know what those words mean?
I'll do it every time.
Huh?
I'll do it every time.
We're gonna do it every time. So core measure means, it has been researched to the point that if you don't do it, you're negligent and can be held liable. So a core measure, if something is a core measure, so our MONA acronym, like all those are core measures. Beta blockers are core measures. Antibiotic after surgery is a core measure. Like there's a ton of core measures. So if you don't meet your core measures, you are giving negligent care to your client. So if for some reason you can't give a beta blocker, let's say their heart rate is like 45 and their blood pressure is 80/20, you gotta document the heck out of their heart rate is 40 and I told the doctor and I didn't give it. Like you've gotta document why you didn't give a core measure to protect your license. So core measures, you gotta do it. Hospitals lose funding over core measure issues. Pretty good. Does he need Lasix? No, he's not showing us signs of pump failure, not showing us signs of fluid like overload, heart failure. So Lasix would be appropriate for him. Pepsid would be great. It would help us like rule out if he was having indigestion. You know, we could rule out that it's not cardiac based, because indigestion could happen, especially as you get older. Activates, that's a new drug you'll learn about this afternoon, so I'm gonna throw that out. Lovastatin, because what's a statin gonna help with? The cholesterol with the atherosclerosis, the narrowing of those vessels. So lovastatin would be good for him. Gotta print this one out. Don't hate on if you chose fruits and vegetables, because you probably are thinking of me anyway. But he does need to limit his salts because of his heart issues. But increasing fruits and vegetables is always good. Alright, what questions do we have about coronary artery disease? it was me and Miss Bridges and Miss Grimes and Miss Henson, like all, Dr. Tinsley, we were all crowded around her going, it's your lisinopril. Where's your husband? Go to the ER. So, they were huge, but she's been on lisinopril, she says, for 20 years. So it does not matter how long you've been on it. I've had patients come in with angioedema that have been on it for 10, 15, 20 years and they still have it. I'm worried about your airway, especially when she came in the morning and she was swollen, and then about 2 hours later, the next time I saw her, she was lisping, and I was like, oh, it's getting worse. It's getting worse. That's when we all crowded around her and made her leave.
They bullied her into leaving.
Yeah. If you know Dr. Haywood, you know you gotta be a bully right off. Because she is stubborn, like stubborn don't cover.
Yeah.
Dr. Haywood, she is stubborn. So she did, but she was safe. She went and got some steroids and got taken care of. So, all right, we've got our
That's pretty.
statin folks. All right, statin people are in the back, so y'all gotta listen back there.
Stats, we're gonna lower your bad cholesterol levels. High cholesterol, yeah, while you're on it, basically, specifically for us, CAD, strokes. Reduce plaque buildup, makes everything worse. Your fundamental mnemonic at the bottom. Liver effects is your biggest thing with that. It'll increase your blood pressure, your pain. Impaired memory, it was a caution for like increased risk of Alzheimer's and dementia the longer you're on it. You give it PO at night because it can cause drowsiness. Oh no, AFib, that's another side effect. It can send you into it. Rhabdomyolysis is the breakdown of your muscles that can release all the bad stuff into your bloodstream. No pregnancy. If you're also on digoxin, you have to watch those levels a little bit more carefully because it has some kind of reaction to it and can send you into toxicity levels with that. Basically, all your diet modifications need to go right along with that.
And what do you need to avoid because this is very liver toxic? Alcohol. Statins are notorious for harming the liver. Like she said, it's the kind of the biggest risk. So there's a lot of times people who are on statins, they have to take drug holidays because their LFTs will elevate. So they'll have to come off of their statin for like a month or two in order to let their liver function improve, and then they can go back on their statin after their LFTs have come back down. So a lot of times they have to do those holidays. But all the doing the good diets and stuff like that, that's what we really need to focus on with them because they may not be able to take their statins. All right, I asked them, I didn't give anybody the nitrate group, so I asked my quick camp of people to make me a nitrate poster. So we talked about nitroglycerin with our CAD. They gave us how to do the topical and the transdermal over here, just making sure that we don't touch nitroglycerin at all, because if you, as a healthcare provider, touch nitroglycerin, what's gonna happen to you? So you're gonna feel it, you're gonna get a massive headache, you're gonna vasodilate in your head, and it hurts like crazy, or you can pass out because it can bottom out your blood pressure. So do not touch it as a healthcare provider, do not rub it in on your skin because it can exacerbate the headache and the vasodilation. We're gonna ask everybody before we give one of the nitroglycerins, have they taken a Viagra or Cialis or something like that? Because we don't want vasodilation downstairs plus vasodilation whole body, because it's just gonna be more downstairs, and then we're gonna have passed out hypotensive individuals. Do we just ask men if they've taken that? No, we gotta ask everybody. Kids take this for pulmonary hypertension, women take this for pulmonary hypertension, and to try and boost sexual effects as well. So we're gonna ask all people. Do we hold it if they've taken it? Yes. We're going the Viagra or Cialis. Do we hold the nitroglycerin if going to monitor them very, very closely. And we're gonna have to weigh the risks and the benefits. Because we know if we give it to them, we're gonna have a more profound hypotensive effect. So we're gonna monitor them very closely. But if they need their nitroglycerin, they need it, but they need it under, healthcare provider supervision. We need to watch that, watch out for it. They do not need to take it at home within 24 hours of each other. I love this stuff. They've got it, like, don't put it in a little Ziploc bag. Keep it there, in its own container. Vasodilator. You have vasodilators, or where is it? Where it says for all things? We also give it for, heart failure. So we give it for heart failure too, for the vasodilating effect. It's this under right here. Alright, questions on any drugs yet? Alright, my Entresto folks. Why did it open it up on here? Just downloaded it again. All the other ones just opened it up.
Can you press the?
Yeah. It's a big, well, the other ones, it just opened it up and like, there's no one there.
Yeah.
Oh, there it was.
Just
Darn.
I love this, by the way. That's a little exhausted heart. Alright, what y'all learn about Entresto?
It's a combination of two different drugs. They're both, vasodilators. It's used in left-sided heart failure.
Say really quick though, it's not actually a vasodilator. It blocks angiotensin II, so it prevents vasoconstriction.
Okay.
Just being more specific, because nitroglycerin is our vasodilator. These don't work that same way. So nitroglycerin is our like vasodilator. This one and the ACE inhibitors, they're stopping your body's natural reaction to vasoconstrict. Just being more specific. Like if we give this, I'm not gonna see a huge vasodilation and like your blood pressure bottom out and stuff like that. Yeah. Sorry.
Okay. Don't use it in pregnancy. Do not breastfeed just because there's not enough studies to say that it passes through human milk or not. Do not take within 36 hours of an ACE inhibitor. Report adverse reactions, angioedema, and that is it.
Yeah. Very good. This one is the one that we give to most all of our heart failure patients now. It doesn't have the same risk of angioedema like the ACE inhibitors do. There's still a risk, but it's very minimal. This is also, like the ACE inhibitors cause that cough that's very annoying and dry, and a lot of people can't tolerate that cough. So we swap into this and they don't have that problem quite as much as the ACE inhibitors do.
So is sacubitril a vasodilator? Because one of my resources said that it was, that's why I said
That
that.
may have some vasodilation effects. This valsartan, like the R,
Okay,
it blocks the angiotensin.
okay. I knew I didn't need to pull that out of thin air.
It just doesn't cause like the hypotension and the massive stuff
Right.
like nitroglycerin.
Okay.
Entresto is the brand name. I won't have that on the test. It will be this combination drug that's on the test. I just can't say that. Entresto is much easier to say. But this one's what everybody is on with heart failure right now. They have good drug reps.
Yes.
Our drugs, what pirate drug?
Exactly like a pirate. So we did amiodarone, Dr. Hicks said literally everybody takes it right now. It prolongs the action potential for the ventricles, basically blocking the sodium potassium channels. It's used for dangerous ventricular arrhythmias. It does have some pretty significant side effects, including asystole and a whole bunch of really nasty heart things. So like it can't kill you. It's lung and liver toxic, has a black box warning. It also makes people photosensitive, and it has a narrow therapeutic range, so you have to check the labs on it a lot. Check your vitals, make sure that you have an EKG. And then we also did lidocaine, which basically just does exactly what lidocaine does on your skin, reduces the sensitivity of your heart, which means that it's less likely to contract for like weird random impulses, so also ventricular arrhythmias, and it can cause CNS depression and slow heart rate. It has a drug-to-drug interaction with beta blockers. I don't remember why, but it does, so there you go.
It increases like the lidocaine effect, is what I read.
Yeah, it's just gonna make everything go, like, kind of potentiate both of them. So amiodarone, so the indications are dangerous ventricular arrhythmias. We're also trying to prevent. So we use it when we have them, and we also use it to prevent them. So we're gonna use it in AFib to try and prevent them from going into dangerous rhythms. We're gonna use it, we can use it in SVT to try and prevent dangerous ventricular. We use it when you have a whole lot of PVCs. So that's why I said literally everybody's in it. If they have a hint of a tachycardic or PVC problem, we throw amiodarone at them to try and prevent the ventricular arrhythmias. If you go into one, we give you this too. So it's just, it's everywhere. Lots and lots and lots of folks are on this. More people are starting to use lidocaine now because it has less side effects than the amiodarone does, but we give amiodarone all the time now. Antiplatelets.
So we did clopidogrel, which is Plavix, and aspirin.
Talk loud, I'm facing that way. I can barely hear you.
So both of them just prevent platelets from aggregating or sticking together and forming a platelet plug. It's used for coronary artery disease to reduce the risk of strokes or heart attacks. Clopidogrel is more long-term use, but if they're having unstable angina, then you can give a big dose of aspirin. They just have to chew it. Nothing really new except the black box warning, which I have no clue what it is. So they're just at risk for bleeding, so we're just gonna monitor bleeding. And just avoid grapefruit, garlic, or any foods high in vitamin K. Tell them to just avoid strenuous activities and to let their healthcare provider or dentist know if they're gonna have to undergo procedures. And the mnemonic is clopidogrel that stops pumping.
So y'all pretty familiar with that one. So, not a whole lot to do with this. Okay, you deleted it, did you upload it?
Yeah, I did.
Yeah,
It's
we did.
It's further up.
Okay. We'll just leave this right here, so my calcium channel blockers. What new did y'all learn for calcium channel blockers?
I love calcium channel blockers because it looks like it took care of many perfusion disorders. So it lowers the contractility, it lowers the blood pressure, heart rate, everything. So pretty much it's very helpful in all those kind of perfusion disorders. The one that I didn't know about was the gingival hyperplasia, the medication that gives you, so usually good oral care, hypertension of course, and the biggest one is avoiding the grapefruit juice. Hypotension is the biggest one because it's a calcium channel blocker. I call it saying calcium calms the heart. So basically it's lowering your blood pressure, so we need to monitor for hypotension. And also heart block, that's the new one that I learned was with the IV use. So when you're, it's a high risk for the heart blocks that you take in your lives. And I guess drugs, if you need to, can you scroll down, like up? Yes, please. So with the pregnancies, it's not much risky, but the benefits outweighs the risk. So it depends on what situation the mother is. You call the PCP if the blood pressure is like way super low. Yep.
So all these drugs, we know that they can drop the heart rate, drop the blood pressure. We don't wanna just hold them and not give them. We always wanna call the healthcare provider and ask if they want them given. Sometimes, like especially with my beta blockers, if I say the heart rate's 50, they'll tell me give it anyway, because it's just not safe to hold it. So same thing with calcium channel blockers. Sometimes you're kinda scared to give it because they're low, but they want you to give it anyway. So it's always, they have to make the call. We just let them know. Alright, so this is a new one for you guys. Hydroxyurea. No, none of that. Okay.
So hydroxyurea, it's the #1 sickle cell oral drug. It's an anti-neoplastic. So with our black box warning, it's going to suppress the immune system, and you're going to have some bone marrow suppression, which can cause leukemia. It can also cause skin cancer. So you want to make sure your patient wears sunscreen and limits sun exposure. When you're handling the drug, you want to make sure you're following disposable precautions. It's also toxic upon exposure, so you want to make sure you wear gloves and don't let it touch your skin. Patient teaching, they want to swallow the pill whole, and they want to watch out for signs of infection. I can't pronounce it now.
Neutropenia.
Yeah, that. And blood counts want to be checked throughout, and the labs you want to look at are increased BUN, creatinine, liver enzyme, uric acid, and then you're going to have decreased hemoglobin, white blood cells, red blood cells, reticulocytes, and platelet count.
So this is a chemo drug. It's an anti-neoplastic, but we use it. This is our go-to for sickle cell. So we're going to learn about sickle cell next week. But this is a great little picture to see what the red blood cells look like in sickle cell. They like to clump up because of their shape. So it's not like they're aggregating and causing a clot. So like a anti-platelet really doesn't help. It's the shape. They get stuck together because of their abnormal shape. So this is a really good drug to prevent that from happening. So we'll learn more about sickle cell next week.
Alright, anticoagulants, we know all about them. They prevent blood clots. Specifically in our dysrhythmias like AFib, because we're at increased clot risk. Our needs to knows, like your antidotes, carbohydrate warfarin, protein sulfate for heparin, and your labs to monitor, PTT and INR. PTT for heparin, INR for warfarin. We all know this, come on. AFib equals afloppy atrium, afloated clot. That's one of our little mnemonics.
I like it. I haven't heard that before.
And then warfarin fights clots in the long war. Heparin works fast at the start of the battle. And another one of our little mnemonics was for the black box warning, E for epidural, because enoxaparin warning is there's a risk for like when I forget what the at-risk was, but I know it was something. Oh, it was epidural hematomas. That's what it was.
It's gonna bleed.
That's right there. Bleeding, yeah.
Bleeding that girl.
Warfarin, warning for bleeding, monitor IR regularly. Big preventative drug. I know this one. Pretty much it.
Very good. I haven't heard of floppy atrium before. That's awesome. I like that. Enoxaparin, low dose heparin, or low molecular weight heparin. Did we talk about what we do with the bubble with enoxaparin? Did we go over that in orientation?
You just push it through.
What'd you say? The bubble?
Enoxaparin, Lovenox.
You don't
Talk
push-
about what do you do with the bubble?
You just push it. You keep it in there.
Okay, so leave the bubble in Lovenox, but you want bubble's up by the plunger. If you don't leave the bubble up at the plunger, there's no point in leaving the bubble. It's just there. So that's gonna push all the med into the skin so you don't get a big old bruise on your belly. So leave the bubble, flick it up, make sure it's at the top of the plunger when you give it. Right, because when you have the needle.
I was like, why am I gonna go needles first? Yours is the top, and I was thinking.
Surely not.
Yeah. Yeah, I mean,
You may have to refresh. Refresh it.
Great, very much.
My bad, my bad.
There you go.
Oh, that's pretty. The coloring.
Which, this is on my brain, this is on my brain really quick, so I just wanna say this, cause I know this is, y'all already know this. Cause we were talking about Lovenox with the bubble, that's a subacute injection, make sure you use your safety device. Make sure safety devices, whenever you do an injection, you hard surface. I know, Ms. Smith got a hold of some of y'all in flu clinic. Look, I tell every single time we validate hard surface for your safety activation device. Make sure you use a hard surface. Don't use your hand, don't use your finger, your leg. God almighty, I've seen nurses do that. It scares the crap out of me every single time when they do their leg. Hard surface, hard surface, hard surface. The other thing I wanted to say that, again, it's in my brain and I meant to say it last week, but I forgot. You guys, y'all let us know if weird stuff happens in clinical, like if a nurse or an instructor, if you think I shouldn't be doing something, but a nurse or an instructor asks you to do something that you know is wrong, like let's say putting in a catheter and it goes in the wrong hole and taking out and trying to put it back in the right hole, y'all know that's wrong. Y'all know that's wrong. So if an instructor or a nurse asks you to do that, say no. And if there's any repercussions with that situation, that's why I can be mean mama and stand up for you and say, no, my student did the right thing. I don't mind being mean mama for you. So, make sure you advocate for your patients at all times, even if someone is telling you something you know is wrong. They're gonna have to give you a real good reason as to why. So we just gotta be professional when we handle those situations. Others, so just, that's it. That's my little PSA that I meant to tell y'all last week. Okay, beta blocker.
So beta blockers, dextromethorphan, urotenolol, for the exemplars, for coronary artery disease, it increases myocardial oxygen demand, prevents ischemia, reduces the risk of angina and MI, and angina increases the heart rate contraction to, which prolongs diastole for better coronary perfusion. And heart failure, it's gonna be improves long-term survival by reducing heart rate, reducing remodeling and then provide, okay, somebody else do this. I'm literally like dyslexic, so I don't know why I'm doing this. So improved ejection fraction. Start slow, titrate slowly. In dysrhythmias, it slows the AV node conduction, useful for AFib, A-flutter, and SVT. So with nursing considerations, it's gonna be the normal ones that we all know, check the heart rate, watch bradycardia, hypertension, heart blocks. For diabetic patients specifically, you wanna watch for the blood sugar because it can mask hypoglycemic symptoms. And you don't wanna give to asthma or COPD patients, it can cause a bronchospasm. For the patient, you want to teach them it's very important to take it the same time every single day. If they stop it abruptly, this is a black box warning, it can cause rebound hypertension. They want to rise slowly, check pulse and blood pressure because it can cause orthostatic hypotension. Report any signs of shortness of breath, swelling, weight gain, or fainting. It can be a sign of worsening heart failure. It can cause fatigue, but it should improve within 2 weeks. If it's any longer, talk to their primary care provider. The memory trick are the B's and beta blockers. Those are the signs and symptoms that come with it. My brain's fatigued. You did great.
just changed something real quick.
Okay, cool.
Okay, sorry.
Refresh.
Okay, here we go.
Better? Yes.
Alright, we had Promolytics. The first we have was Altaplace and Rentaplace. I'm hoping I'm saying that right.
Good enough for me?
Okay. When they're used is for heart attacks, is to help open the blocked heart artery, ischemic strokes, to restore blood flow to the brain, and then pulmonary embolism for when the clot travels to the lungs. The mechanism of this is the medicine turns the body's natural fluid through. They change protein called plasminogen into plasmin, which dissolves clots that's stopping the blood flow. So just think of them as to drain clear for your arteries. For a nurse, you want to watch for signs of bleeding, so intracranial bleeding, ischemic strokes within the last 3 months. Do not mix with other IV meds and uncontrollable hypertension for contraindication, And you want to look for signs of bleeding, gums, urine, stool, bruises, sudden headaches or confusions. Could mean brain bleed, and changes in the heart rhythm or chest pain. The nurse needs to monitor those, but also do your vital signs, heart rhythms, neuro checks, and closely during and after giving this medication.
So we'll learn more about these next week, because next week we're gonna do our pulmonary embolism and stroke content. So we'll get more into these. We just need to know that these thrombolytics are very dangerous drugs. Very, very dangerous. They're life-saving. Like, they can save your life, but I hope you don't die just because we gave you this drug. So we're gonna weigh the risk versus benefit before we give you this medication. So they gave you some good contraindications over here. We're gonna get into those even more when we actually start talking about strokes and stuff like that. So we're gonna get a little bit more detailed with this. So yeah, we'll get to that. All right, how we feel about meds? Pretty good? Pretty good? Yeah. Any questions for any of them?
These are all the meds. We need medical tests.
Do it.
Are these all the meds?
Yeah, these are all the med classes. We've got some of those other meds that are thrown out there that weren't in class, like atropine and adenosine. Like, we had a couple of those. Our vasopressors weren't in